on P8 Parkinsonism, as this was work as part of the Phenotype February. Today is March 22nd. Go ahead, Dr. Wu.
Great. So I can't share my screen right now because I'm on an iPad.
Yeah.
But so Northwestern has an Atlas instance. We still don't have full access, so it's still not fully populated, but at least we can start doing some line level cohort evaluation of criteria, as you'll see. I looked at the cohorts that exist in what you have done as part of Phenotype Phebruary. There's a data set of a number of cohorts at data-odyssey, data.odyssey for Phenotype P8, and I reviewed these. So here are the overall comments. I'll just run through my overall summary here. Number one, the overall incidence of Parkinson's disease with the unanimity cohort overall is about 0.5%. And that's across all databases combined. It varies a little bit by database, but that is a good approximation of a reasonable approximation of population incidence. So we're happy with that.
That's good.
There were no major issues with the data source and orphan concepts. Orphan concepts were no issue. Data source is useful because it does subdivide the different data sets into kind of three groups. One data set is pretty granular with the kind of secondary Parkinsonisms. Another cohort of another type of database are those that have just pretty generic Parkinson terms. And the third type has almost nothing other than just straight Parkinson's and maybe one or two buckets. So I think that will prove and has proven to be interesting in terms of different performance characteristics. But overall, all the cohort concepts that are included are correct. So I can pass that. Okay. Then we look at the cohort counts and the criteria. And I think the major issue right now is that there are the first criteria after being adult and having a Parkinson's disease condition occurrence is that you need to have 2 Parkinson's disease conditions within the 3-year period of time. And that actually surprisingly excludes a significant number of cases. And that's unexpected. In 3 years, if somebody has Parkinson's disease, it is unusual to have a drop-off of, typically on these data sets, it drops off about 40 to 60% of the cases. That's very high. We don't expect that. In Parkinson's disease, if you have it, you should be seen at least twice with that visit occurrence during 3 years. So either this is because we are using the most recent entry criteria of the cohort. So we're only looking at the last 3 years. And so maybe they're all end stage and maybe they get seen once and everything else is all palliative care and dealing with other things. Or the logic is not quite right. And if you look at the Atlas,
logic now,
no, doctor, we are requiring from that latest time, we're requiring that they have 3 anytime prior. So we are looking to make sure that we're not looking forward after that latest
correct
one.
Right, we're looking back in time, but it is unusual to look back in time for 3 years and only find and drop off 50% of your cases.
So I will say that generally, whenever you require a reoccurrence of any diagnosis codes within a time period, we generally see a drop of that much in our databases. Usually it's around 50%. In any I'm just like any diagnosis, unless the ones that you don't see a big drop is acute events, but especially chronic diagnoses, we see that, like, remember whenever we require a second diagnosis, we see 50. That's
yeah, it's so it is an observation. It is true that in observational data we do see is for some diseases a significant drop off, even though our expected a priori is this is a chronic disease. This is something that the person is expected to come over and over again, and we should see this diagnosis over and over again. Why does that happen? We don't know.
No, but it could be. So what that means, you're requiring 2 or 3 diagnoses. You're requiring two other than the one, other than the latest, or just a second one other than that latest?
The latest can be included.
Can be included. So we're basically looking at 2 codes, correct? So what that means is that you have 50% of the people who you captured at what you call latest diagnosis, but that's technically their only diagnosis. And that is, so if we believe a person who truly have Parkinsonism has to come and have a follow-up, and we won't believe in one diagnosis, so that could be all false positive cases, maybe rule out, like basically they had a rule, like they had a diagnosis and then it was just given to see for ruling out purposes. So that's one of the reasons we see one code that never get observed again. There are some databases, which is non-US databases. So things like France, Australia, Germany. You looked at all of them, right? You had, so there are four, let me finish that idea. There are some data, the European databases actually does not allow for a repetition of codes because the way they curate that data is using that problem list of the entire medical record, and they only do it once in lifetime. So once you have it, you can't have it again. So but that is non-US databases, and those are just France, Germany, I'm not sure about Australia, but France, Germany, there's one more, and of course CPRD, which we're not looking at. So those we understand that you will never see a second code for most cases. Those are just related to how they curate the data. But the US databases, if you don't see another code, that means that no other code was really observed on the claim.
So there's 2 points here. So Aza is right. So in electronic health record data sources, there is the construct of a problem list. And once you have it as a problem list, you would expect that to persist as long as it is a problem. And you don't need to code it at an encounter level. You code it as a list of a problem with a long period. So that can explain why we observe it in some in some electronic health record type data sources. In US claims data sources, though, there is a coding practice which is at the encounter level. So for every encounter, there are treatments or procedures that are done, and then there are corresponding diagnoses that justify those treatments and procedures. So if you're managing Parkinson's disease, you would create a procedure or dispensation of a drug or titration of something, which is for the management of Parkinson's disease. And you would justify that with the diagnosis of Parkinson's disease. And so every time-stamped observation would have the diagnosis of Parkinson's disease. That makes sense. Now, what you're observing here is 2 important things. One is you made a statement, which is that the incidence observed after the application of these inclusion rules is 0.5%, and that is in line with expectation. So you made this. So that statement implies that despite the loss of 40% of the persons, the incidence rate is still in line with expectations. And then the second statement is, who are these 40% that we are losing? These 40% that we are losing are persons who have the code only once in their life and do not have this code again. Now, Aza asserted that sometimes these are people who are suspected to have Parkinson's disease and maybe a rule out or maybe things. It could be possible, that's a hypothesis. We can test that hypothesis by building a cohort definition of persons who have Parkinson's disease diagnosis only once, do not have a subsequent Parkinson's disease code, and are observed in the data for like 2 years after or 1 year after. So essentially, these are people who get a diagnosis code today, are in the database, followed up for another year for other diseases, and are but do not have a repeat code of Parkinson's disease. And we can check by looking at characteristics of these persons to say, oh, the persons with only one code truly cannot be called Parkinson's disease, because in real world, they are being coded even for persons with suspected Parkinson's disease. Possible. And that's something that we can check.
Let me ask you this. What you have another criteria for treatment. How much loss did you have with the treatment?
That was also relatively high,
Hmm.
unexpectedly high. So with the medications, it was up between 15 and 70% met that criteria. So the inverse of that is how many you dropped off with that medication list.
Yeah. So I'll tell you
That
something.
seemed relatively high to us.
Yeah. So, that is not high compared to other situations. So he said, hold on. You said about something to 70% met the criteria. So up to 30% lost
Right.
were lost. Yeah, up to 30% were lost. Have you not have that first criteria of the second diagnosis, you would have lost either way more. So there's a bunch of population in any chronic disease that you will find have a code and don't have anything else, don't have a secondary code or confirmatory code, don't have a treatment, don't have any patterns of being a patient of that disease. And that's, people like to think of those as noise. Those are false positives. That's why we're having all these rules. But we can definitely test and examine that. But yeah, like if you have like, the reason I ask you about the treatment is like, I anticipate that those people that you lost in that first attrition because they don't have a secondary code probably also don't have treatments.
So this is the code definition that has
Yeah, so this is why I think I started off by saying we were pretty excited to have our own atlas so that we can actually dive in and do some sampling here, because we are interested in those who have true Parkinson's and are not on treatment, because there's that. And I think these false positives are of great interest.
So you're saying, in one data source, so this is a rule called gain. The gain will say how many persons will you gain if you remove that particular rule. And
is that how you interpret that? Okay.
yeah. So here, for this particular data source, the total number of cohorts, the cohort number of persons in the cohort is 67,000. In that 60, and that number is here. In this 67,000, there are 6 rules that have been applied, and before applying the rules, the number of persons who met the top criteria, entry event criteria, is 242,000. And individual rules, if you remove the rule that is age restrictions, then you will gain 91 people. This is the 91 people that are not affected by any of the other rules. So that's what it means. Like there may be, if you click on the button meet, that says 241,000 of the 242,000 met the adult criteria. So the difference here is about 1,800, I believe. So about 1,800 people were actually less than 18, but only 92 of them met, or 91 of them met the 18. The rest of the 1,700 would have dropped off by some of the other rules. So that's the interpretation of it. So with that interpretation, the Parkinson's disease medication is 57,291 persons met that rule, and only that rule.
Right. So gain is that rule and only that rule. Yeah. So those might be people that get treatment and do not even have Parkinson's, right?
No.
So these are the people that.
No, it's after applying the rule on top.
Yeah. So the 57,291 people do not have Parkinson's medications.
Out of the people who have, so it applied after the rule that was applied on the top of it.
Okay.
So it's sequential.
So the gain is sequential, unlike meet. Meet, I think, is overall, right?
Correct.
Meet is just in the whole population, how many met
Yeah.
that rule?
Sequential is remain.
Right. Remain is clearly sequential. So gain, is that sequential? It sounds like it is.
No, gain is, so if you remove the adult rule, you will gain 0%. That's only 91 people. So you can, this basically is telling you that this rule is not doing anything because the persons who are excluded by this rule, and that's 0.7% of the 222,000, which is 1,800, also are excluded by other rules. There must be a clearer way to describe it.
Yeah, well, there's an info button that I can review in more detail. But anyway, I think.
Anyway. Yeah, I mean, so you're looking across multiple data sources with different like data processes behind it. Do not think when you say that's not something we expect, do not think of that person that you're capturing in these databases of having one Parkinson's that meet that first entry criteria. Don't think of that person as the typical patient that you might see that came to you with a diagnosis of Parkinson's. And that's what I'm saying, because those are claims, those are, there's also coming at all different type of institutions, including an outpatient GP coming for the first time. So don't think of, especially if you're functioning out of a high specialty, high tier organization, don't think of your patient, the person who come to you with Parkinson's are the person you're picking up in that first entry criteria. That person that you're picking up at that first entry criteria is captured along a spectrum of settings, including like anything that that people get reimbursed for, including a GP, including coming to the ER and the doctor is not sure what's happening and think maybe that person has Parkinson's and put the claim there because they need to be reimbursed. That's the whole idea of requiring that secondary, what we call confirmatory diagnosis. Like you want to see it again to think that at least it's truly a patient with Parkinson's. But yeah, I mean, I can't tell about the truth, but I can tell that pattern of loss of that many, that proportion is very typical.
Yeah. So I think that's the bottom line. That was helpful to me to understand that this is a typical drop-off you see. We are, of course, intensely interested in identifying Parkinson's from different data sources, including primary care only settings and so on. So this is really, really helpful to us. And the 0.5% incidence is probably underestimate. I think that is acknowledged as an underestimate. So it's in line with what's published, but it varies quite a bit. So I don't think that we would hang our hat on that and say, oh, we're done. I think there's more to do with this. So I think this is a tricky enough condition that I think we have some proposed next steps, but it will be important for us to be able to query our UCLA and our Northwestern databases. So, yeah.
I do wonder if you're worried about, like, to narrow it down to like what is the concern? If we're worried about losing potential true cases because of that requirement of a secondary diagnosis, I think we definitely could experiment, which is making that cohort of people who have only one diagnosis, as Gautam proposed, and see who these patients are, what's their profile, and confirm that they truly don't have the disease, or at least have an idea of what their profile look like. But if we have concern, you can't, if you want to increase the sensitivity, you could make it an or statement with the treatment. So basically, I'll believe that the person has Parkinson's if they have a second diagnosis, or they have one diagnosis but they receive the treatment. That would probably make your numbers slightly different. Basically picking up some of these patients that you lost. But again, that depends on your expert opinion of like what's what's the probability that somebody has a code and has a treatment and doesn't
Yeah.
really have Parkinsonism?
Yeah, so I think at a population level and in these databases, I don't think we have the true answer. I think based on the data that we have used as preliminary, we think there's a good shot at getting, 80% specificity with at least 70 to 80% sensitivity. So we're just like everybody else, we're trying to maximize both, but we understand there's a trade-off, and it may be that we have to accept a fair drop-off of the 50% of meds and two conditions. I have one follow-up question, and then we'll go on to our any other observations I made and next steps. The question is, I understand ETL is different, and so that problem list may be represented as the predominant way of representing chronic conditions in some databases and not others. Is the only way to tell this by looking at the drop-off with the two condition confirmatory? Like, how do the other definitions handle this? There's no flag that tells you that the ETL did it this way versus that way, right?
It's not the ETL. So it's not the ETL, it's the source data. It's not the ETL,
Okay.
it's what's in the, it's when, that's why there's nothing you can do about it. It's not the ETL,
Right.
it's what comes from EHR data sources. Conditions are based on the problem list, which is a static situation. They don't reoccur. It's not the ETL. The ETL don't drop on other conditions if it exists. It's just that it's what we call data curation and proposition. It's what comes with the data. The claims have the nature ability to reoccurrence because they are captured on the encounter level, not on the medical record level.
Got it. No, that makes sense. Okay, so we don't have any way of detecting this other than looking at our criteria, basically.
So we can infer it by looking at the database level summary reports. So there's a tool called EARS and there's a tool called Achilles that is not at the study level or the cohort level, but the entire database. And if you observe that for the number of records per persons of the diagnosis code Parkinson's disease occurs only once per person, then that data source is probably a problem list based data source. But if you see 25 records per person, that's probably a claims type data source.
So can you go back to your attrition? France and Australia are in there, right? Like, but from what I see, you're generally it's about 50 to 60%. Do you see something that is like 90%, and then you know that it's just not applicable?
Yeah. So here has one Parkinson's disease, has at least one.
No, it was 30 to 66% that met the criteria. So the one that had the largest drop off would be the CPRD data.
Yeah, CPRD by definition. So you definitely, CPRD is one of those data sources that you cannot require a second diagnosis. Like they're very yeah, so this is not true. These people are, because they definitely curate on the problem list, and they do by curation of data, they don't capture the occurrence of codes. So, and also CPRD is not something we should look at anyways. It has its own governance, and I would just remove CPRD from your assessment.
Okay. The second one was Germany and Australia. Those are the next two.
Yeah,
that was Japan, and then after that, we're at the 50% mark with IQVIA. So yeah, it's Germany, Australia, and Japan are the ones that otherwise had a fair drop off with this condition.
So they have the fair drop off.
Yeah.
Yeah. This is the nature of the data for those. Again, those are the.
But if it is purely a problem list, why do we see more than? Why do we have even some people satisfying the criteria?
Because you're looking across 3 years, so the problem list may change. They're not capturing every encounter. They're capturing every change in the problem list.
We call that patient level data, and different doctors can choose to populate the problem list in different ways. And Parkinson's is chronic enough that sometimes it gets added, it gets removed, it gets added. Different variations of Parkinson's get added over time. So I'm not so surprised by that.
So I think, yeah,
Okay.
so I think the way you frame it, you framed it perfectly. So like, is it an event level data or a person level data? And if it's a person level data, then we can't, applying the rule of requiring multiple encounters with the same diagnosis becomes difficult because it's a person level data and the person gets the diagnosis of course only once. But if it is an event level data, like a claims data, yes, it makes sense to apply multiple events because every encounter you should expect the diagnosis.
Okay, so it sounds like we might have to evaluate some diagnostics. If you could, Gautam or Azza, send me that tool you mentioned on database level diagnostics of prevalence of conditions, that would be helpful. And then we can implement it in our site as well and see. So I think those are the main things. Yes, go ahead.
Yeah, just to make sure before we move on to that point, there's no metadata on the data sets that would allow us to sort of combine these two different worlds, you know, kind of the encounter-based versus person-based, so that we can have one definition that sort of attaches correctly to the different data sets, correct? These are all just within the data sets. Does that make sense? What I'm trying to achieve?
Yeah, I think to reframe Andrew's question, it's sort of like, can we create one cohort definition that says if you're a person level problem list focused, then run this criteria, but if you are not, run that criteria, versus the way I was thinking about it, which was let's do a diagnostic on the data set. If you're this kind, run this cohort published definition. If you're not, run that one. So either, Andrew, does that frame it? Sort of?
Correct. Yeah, correct.
Yeah.
Like, can you build it into the cohort so it's one cohort published definition, or do we have to just, you know, depend on the analyst for your particular site or owner of the data set?
So there is one big distinction that you can put in is just the nature of the data, and that's usually on the data level level. Is it an EHR or is it claims, right? So like at least for us, that's what's very clear. That's why, like, I know Australia, and especially European electronic medical records, like in Optum EHR, which is another data source that is listed here, you actually see encountered because they do capture encounter in addition to the problem list.
Yeah, and I work in EHRs, and of course in America, and pretty much our data extracts are predominantly encounter based, and that is how California Registry is doing it. We do have the problem list, and we'll often pull both, and then we have to handle both when we do searches by diagnosis.
So I have to say, like in J&J, because we have both, we just handle it. We just handle. We run cohort diagnostics, and we observe that there's something that the patterns observed in those 3 databases are different, and then we justify it by knowing the data curation processes, and we just say that data. What we say is that definition, this database failed that definition. It's not fit for use. And we just fail it. It's
yeah, it's like a statistical pre-criterion. Are you normally distributed? If yes, now you can run your test.
Yeah, I mean, we also partially because of that reason, we avoid that second diagnosis, and we try to use an or statement with other, because the whole purpose of this or statement is to remove those false positives. So when the database is not applicable for that rule because they don't do encounter level capture, then we start thinking of what other rule can we apply using an or statement that would do the same. That would have the same function as a second encounter. So treatment is the biggest is the biggest thing, because like, okay, I don't see a second diagnosis because I can't see the encounters, but I see treatments because it comes from a different data domain, that's drugs. But if you still wouldn't trust a case that has one diagnosis and treatment, yeah, so the game we play is try to come with an or statement and put a rule that would do the same functionality for that data source.
Yeah, well, right. So that would be in the Parkinson's world, trying a treatment and trying it for a sufficiently long period of time, because it's pretty routine to try a med and see if they respond for 6 months or a year, and then give up on it if they're not responding. And therefore you no longer believe they have Parkinson's disease. That can take 6 months, a year, 2 years, and that makes it a challenge. But that's okay. This is a proof of principle work, which we intend to publish. We are not going to solve everything, but I think this is a good start, and we're going to continue working on this.
And if your use case is primarily going to be on databases that are EHR that capture, or EHR or claims that capture encounters, then you don't have a problem, and you can ignore what you're observing in Australia, France, and Japan.
Right. Yeah.
Yeah, that's exactly right. It's kind of, can we include them, or do we just need to restrict our analyses to certain data sets? So I think that's fair.
It all depends on the use case. So if you're thinking of it as a US registry using data coming from the US that capture encounters, then you're good.
Yeah, yeah. I mean, our use case is dual, right? So our first use case is be hypersensitive and capture everybody who might have Parkinson's, because that's the nature of a surveillance registry. But within that population, we want to have, and we have not defined this, but for epidemiological purposes, what would, and neither one of us are epidemiologists, but for epidemiologists, what certainty do you need for a specificity to count the Parkinson's disease cases, as opposed to the possible Parkinson's cases?
Yeah, I like generally what you'd apply, the unanimity definition or the other one, that's what epidemiologists do. They're gonna look at other domains of data to filter out possible false positives. So a second diagnosis, a treatment, remove the differential diagnoses or conditions that don't generally occur but can be confused with Parkinson's. Yeah. Like this is the approach. Like that's what's done across all these different diseases. Yep.
So the issues so far, the issues that we have discussed so far is the differences by data sources. It is to apply a definition that requires a second diagnosis code. We need to know if the diagnosis is assigned at the person level in the data source or at the encounter level. If it is a person level data source, then the definition that requires multiple diagnosis code may not be appropriate. Yes, because of the data capture processes. So it's important to know that. That's one insight. The second insight that we have is the use case, which is the sensitive versus moving the epidemiological use case of being more specific. In the sensitive use case, a person with a diagnosis of Parkinson's disease could be allowed in, but we are observing a large drop, 30 to 50%, when we use the second or subsequent diagnosis. So the question here is, are the persons who are identified by only one diagnosis a false positive or not?
Right.
And if you think it's mostly false positive and they're not contributing to sensitivity errors, then you could use the more restrictive criteria for your sensitive use case. But if you believe that we truly have true cases in the sensitive definition, and we are having sensitivity errors, then we have to explore and see who are these people that only have the diagnosis once, and try to figure out if we can tease from them the persons who truly have Parkinson's disease by having some innovative routes, such as treatments or long treatments or something like that.
Yeah, that's correct. And that leads us to what we're planning as our next steps. So one is we need to apply these to our own data sources. Yep. So we haven't done that quite yet. And we need to check for each of these criteria, who's being left in and out, particularly the two drop-off ones, the Parkinson med ones and the two code ones. And the two code ones, we got a lot of insights from the discussion today.
So in terms of the tooling, I'll introduce you to a tool if you want later on.
I think we should. I think yeah. Let's move on the other your other observations.
Yeah, I think those are the main observations.
Okay.
I think I was on the next steps, and the next steps are besides reviewing, auditing cases, the other is, and we have a question for the group. We would like to evaluate the re-indexing of this because the incidence diagnostic is hard to interpret in this group, right?
Absolutely, yeah.
So
what does our incidence tool does? It actually still takes the first diagnosis,
No,
it's
it,
I
it
think
takes
it's the
first
cohort entry.
or start date.
but it drops. It drops anybody with
No, it so
most people the same. Yeah, no, you're right.
no, it does not look for occurrence of the codes of in the entry criteria before the persons.
Yeah, I mean the age is quite old in some of the data sets, so I think it is looking at the cohort entry criteria, which is the
Absolutely.
latest, most recent. So so we are. I don't think there will be a huge drop off, and probably not a huge difference now that we have insight about what you're observing in drop off. So I think it's pretty reasonable to take all the cohorts we've developed and then re-index them. It would not take too much effort. In fact, I may have already done it.
I think Patrick did it already, and there's a little bit not like he re-indexed it already, and we looked at it. You're capturing, I think, 99% of the same exact people, but we have like that edge cases of some people not meeting the criteria in one and vice versa between like the 3 years back and the 3 years post, and that just because of some like edge cases related to when you required that year, and but you get very, very, very close. So if you want us to, we have those, if you want us to dig and get that number to be 100%, that will require some digging and some playing with Atlas.
No.
If you don't care and 99% or 98% agreement of the people between the 3 years prior versus 3 year post, then I think we're good.
Well, so one, we're very, very interested in those edge cases, right? So as neurologists, the edge cases are going to be ones that are picked up by the earliest criteria that meets 3 years and having 2 Parkinson conditions and so on. And then they turn out 4 or 5 years later not to have Parkinson's disease. That is absolutely fascinating to us and has not been well explored. That was the nature of what I submitted as a very basic idea to your Sisyphus challenge, right? There is not been any.
Real quick.
Yeah.
Just to make sure that we're talking about the same kind of quote unquote edge cases. We aren't that sensitive to the 3 years, right, Alan? I mean, that's kind of a made up number, whether it was 2.5 years or 3.5 years. That's not making or breaking the like early quote unquote cases or not. So I don't think we care about that number as much as we care about the edge cases of kind of early Parkinson's, just to clarify like what we're talking about for edge cases.
Yeah, so the 3 years is arbitrary, absolutely. The 3 years came from a publication from 15 years ago, and so they could only review 3 years of paper charts, right? So yeah, we've done look at even machine learning things are just looking back 1 year at this point. So it's pretty arbitrary. What Andrew's getting at is what we really, really want to know, and what we really do not know in observational research is a natural history of Parkinson's, right? That is what we are betraying here, that we want to be able to be sensitive to pick up Parkinson's as early as possible. We want to see them evolve into a cohort of definite Parkinson's disease, and we want to suck out the ones that bounce into a non-Parkinson's feature. And we would predict that some people, due to the nature of electronic health record data, kind of bounce around a little bit. there's a little uncertainty, and we would be happy to help figure out some kind of definition by which we can track this evolution in and out of cohorts.
Okay, I think there are two different things. So I get your point. So let me just rephrase to make sure that we understood. You are interested. So if we think of a patient's journey in an electronic medical record or in observational data, let's say on average, we usually have that 3 years time frame. That's usually our average of how long we capture a person in the data. So you're thinking there's this group of patients who come to the data at the beginning of their journey. We capture them. Then if we look forward for, like, say 6 months, we will be able to assert that during that time frame they met the criteria of being a Parkinson disease patient. Okay, throughout our assertment of all these diagnoses, treatments, so forth. Then we are looking in the earliest event perspective of things. We are capture these people the earliest of time that they met that criteria, and we're assigning them to have the disease the very first time they have a diagnosis and they met the criteria. So that is the prospective perspective, the earliest event. And that what I meant, we want to implement that, taking the same idea of your latest event criteria. Then you have another cohort, which is the same kind of people, but you're capturing them at the end of their journey, where you're like saying, okay, I'm capturing them at the end of their time observed in the data, but I'm using their history to assert that they truly had Parkinsonism at the time. So here is you implemented that, and we have an implementation of the first case. But the edge case is the people you're thinking of. The edge case is the people that when I looked at them at the time they came to joined the data and joined their journey. At the beginning of their journey, they were categorized as Parkinsonism. But if I looked at them 3 years later, they are out because they somehow stopped meeting the criteria. So this is a group of people. There's the other group of people where at the end of their journey, they met the criteria, but when I looked at them at the beginning, they actually were not in my Parkinsonism label, because, and that's maybe because they didn't meet the criteria, and then their clinical team came to the conclusion that they actually have Parkinsonism at the end. So there's like 4 different buckets. And this is what you, like that edge case is the middle, where they met the criteria in the beginning, but they stopped meeting the criteria at the end. So, okay, so why don't we first, so we have the latest, we have the one you implemented. Let's take the earliest event version of it, which we kind of have. Gautam and I can look at it again because it's like Patrick implemented that, and make sure it's true. I do want to caution you that the game we're playing a little bit is not, some people might fit in that edge case, but not truly because they changed what are, or the clinician changed what they are. It's just because every time we bound a criteria, all our criteria are bound by time. And so we're at, to your point, we put the 3 years as an arbitrary number, and those buckets gonna change depending on what is the time frame we're using as assertment. So if I say, like when Patrick implemented that, doctor, he actually used the entire 3 years. So in principle, it should be the same time. It should be the same people, because when you looked back 3 years and he looked forward 3 years, so we're using the same amount of time to assert a case. So there should no be changes. You know what I mean?
Well, yeah, there is a change, because the entry criteria uses the Parkinsonism broadly defined condition set, whereas the criteria for the cohort is using the specific Parkinson's disease.
That's in his implementation.
Right, because
Okay.
so we anticipate the 3 years in the most recent is going to be that meet the criteria at the end. If the person is long enough in the data set, will
Yes.
be different than the 3 years when they first
Okay.
meet.
Okay.
But you're right. I think we are also intensely interested in a publication that says, hey, 1 year time frame shifting over time, 2 year time frame shifting over time, 3 year, 5 year. This is the effect it has on the arbitrary nature of trying to find epidemiologic criteria for counting Parkinson cases.
Yeah, and we see this all the time. It changes what
So
and that's in epidemiology. It's called
can we use the phenotype sensitivity to explain this idea of how estimates can vary because
yeah, but I think we there's a term, anyways, there's a term of like, you have to define your assertment time. You have to decide what is the time in your journey that you're using to assert a case. And then the rest of the time, if you're running an analysis, will be your follow-up time. And you don't want to mix your follow-up time with your assertment time, because that's when you run into those survival biases. But whenever you have the whole cut of the data, you decide what is the time that I'm using data to assert, to classify people into in or out. And then the rest of the time are used to monitor, to see what happens to them. And it's up to you how you define these times. But if you're going to use a 3 years, then you're probably going to have more truth, because we're assuming that time bring more truth. But you're going to lose all your time for assertment, and you don't have follow-up time to study these people for anything.
so we have 9 minutes, 8 minutes.
Okay.
What are
Yeah.
the next steps? What so
Yeah,
Dr. Wu, you're leading this. We are here to help you. What specific action do you want to assign to the community, OHDSI community, us, me, to help you get this to the next stage, wherever you want?
Yeah, I think there are 4 cohort definitions for the unanimity. I am taking care, and I actually have made some observations on the tiered specialty, which we won't get into now, but it's actually fascinating. And we'll do more digging on that, but it's actually looking kind of promising in the 5 databases that have specialty. I think it's very exciting, more sensitivity and more specificity. So, so next steps, if the OHDSI team can help with running whatever data we have, the cohorts, the 4 unanimity definitions, and make sure they're all re-indexed. We want to know if those 3 years, when they first meet those criteria, actually are the same or different than the 3 years from the most recent.
Yes.
But I think that would be useful to compare.
Okay, and you do want to use the entire 3 years in both cases. Like when you look forward, do you want to look 3 years for people to meet the criteria?
I think so.
Okay.
And if only because we can compare it with what we already have, right?
Okay.
I mean, I think ultimately, yes, we will want to do different timeframes, but again, resources are limited, and we need to do some auditing on our side. The other task that needs to be done, re-indexing. Oh, and I wanted to set up, because of the nature of what we're trying to do is compare relative performance of these things. I still think there is benefit to setting up for PheValuator, and I sort of think that re-indexing to earliest condition makes more sense in the way PheValuator was designed. So I see 2 steps. One is re-index to earliest, so I can compare with what we've got, and a set of re-indexing to run PheValuator. And I already have an X-spec and X-sensitive in Atlas demo that is both forward-looking and backward-looking.
Can you go out and look at, I'm out of my team. I think Joel did run something. Joel, did you run PheValuator?
Can you comment on it?
No, did you run it? Did you run Parkinson's disease?
Yeah.
I think so, yeah. I'm out of my, hold on, let's open, so we have.
So we got Joel here in the room.
Oh, great. You guys are all in the same office. Yeah, I was concerned about running it earlier because our cohort definitions were all indexed on the most recent occurrence. And I was concerned it was hard to interpret.
Let's see, Gautam, you can now, you're in Teams, right? I'm in J&J Teams.
I'm in OHDSI Teams.
Yeah, so can you navigate to the file? It's in
Yeah.
Phenotype February, and then we have a file just for.
And then the
P-value.
question would be, was the X-spec and X-sensitive using the ones we had on Atlas demo? Because I think Joel
Probably
ran this
not.
last year.
Probably not. Yeah, probably not. But it doesn't matter. We would rerun it. But let's see what he see.
Is that the file? He's gonna come. Joel's gonna join us in any time. So no, let's tell him to.
No, that's filtered. It's filtered.
I do have a hard stop at 9:30, so
There.
Okay.
we can certainly continue this.
He does have re-index definition, so he's used it.
Yeah, he used Patrick's, which is slightly different, but we can redo this work. But things don't move crazy in PheValuator, so that gives you an idea.
Yeah, so here.
Okay.
is-
And
I
you
don't
use the
think I've-
re-indexed, right? The
I
ones
do not
with.
think I have seen this yet.
So, yeah, so here is the Parkinson's disease. This is correct, right, Joel? Right. So he's used the re-index definition, and we can cross-check the re-index definition. Maybe there is minor changes, but it wouldn't change the estimate dramatically. So we are seeing based on
And
data.
you use
source-
your own X-spec, right? You didn't use what he proposed. Yeah.
So if you look at the data sources, like this data source, which is the CPRD data source, and we're not using this, but you can use this just to get an insight. Because it does not
Allow for
reoccurrences, we are seeing a very low sensitivity, which makes sense.
Which you already anticipate from Cohort Diagnostics when you saw that big drop.
And in other data sources, like the US claims data sources, you're seeing a sensitivity of 0.7, a PPV of 0.94, and that is informative here. So this 0.71 is the concern that you have, which is if you use the rule of acquiring this multiple diagnosis, we're losing a large number of people.
Wow.
That is probably explaining the 0.71. So if we are able to identify true cases among the persons who only have one code of Parkinson's disease, this sensitivity metrics may go up from 0.71 to 0.9, maybe, or 0.85. I don't know. But among the persons who we have identified using the Parkinson's, using the unanimity definition, we have a PPV of 0.94. So that's good, but
you do have so you have a less sensitivity even in Medicare and Medicaid. So you see, like you're on the 50%. You're slightly better in CCAE.
And I would anticipate Japan does more poorly.
Yep. You're on the 6%.
Yeah. I mean, and so the sensitivities make sense, right? So that depends on the percentages that survive, the remain cohort counts as a percent in each cohort. So that those numbers on sensitivity kind of make sense in terms of the cohort numbers I looked at. The specificity is hard to interpret, right? We don't know what the X-spec is here, and it's likely conservative. So
you're right. You're right. The unanimity, the one you have with the specialty, is actually performing better.
Well, those need to be combined. The numbers need to be combined, right? When you do one of three, you need to combine all three. When you do one of six, you have to combine all six, because each of those definitions is selecting a specific cohort of time uniquely. But yeah, I would have to think about how to interpret those.
Okay, but let's if you stay on unanimity, so we may change. So we'll make some changes. We'll look at your X-spec, and then we'll look at the re-index to make sure that it's using the same entry event as the one looking at 3 years prior. But yeah, but this is in line with what you expected. It's 10:30. We gotta go, but
yeah, this is great.
This is great.
I appreciate
what
this.
you expected. Yeah. Okay. So next we're looking at the re-index cohort. We'll talk to Joel more about PheValuator, and then you will look into your implementation. Correct?
Correct.
The two data.
We'll do a deep dive into our implementation. We'll plan on touching base no later than a month from now. Because I think we're all on other things now this month.
Yeah, we want to make sure we don't lose momentum, and we'll you know, whenever you ask for time, we will try to oblige and get on it.
But on
We
our end,
appreciate it very much.
on our end, yeah. So we're looking at, we're gonna look at the re-indexed and the X-spec. That's our.
Yeah, I mean, Gautam, Azza, we could try to touch base in 2 weeks, just as a quick touch-up. I think
sure.
that would be good. Okay.
Okay.
I will
Thank
send out
you.
these notes. If you are able to make a forum post with a summary, that would be awesome. Thank you.
Yeah, I'll work on that. Thank you.
Thank you so much. Have a good
Okay,
one.
bye.